Okay, this won't be very long because we already finished increased ICP. We're just using another example here of a condition that leads to increased ICP. So the first exemplar you used was stroke, which was in MedSurg 1. So this is another one. TBI has 3 categories. We can have mild, moderate, and severe traumatic brain injury. Most common causes are accidents, major trauma. Others are from falls, either from being drunk or people with epilepsy or any other seizure disorder. They can be open or closed. They can be, like I said, they could be mild, moderate, or severe. The Glasgow Coma Scale scores range for mild is 13 to 15. That means the patient will have some confusion, some memory loss, or some loss of consciousness. But the loss of consciousness in mild is usually under 30 minutes. Whereas in moderate, the Glasgow Coma Scale is now between 9 and 12, meaning the patient will have some deficits now. Besides the altered level of consciousness, they will have problems with motor responses as well as with your verbal. There will be some confusion, and eye opening will probably be not spontaneous anymore. And the most severe, of course, is a Glasgow Coma Scale score of 8 and below. For severe head injury, these patients most probably will have a depressed respiratory rate already, leading to they will need to be intubated at that point when they reach a GCS score of 8 or less. Here are different mechanisms of injury. You can have just one focal injury, or what we call primary injury, or that's coup. There can be a secondary injury of coup contra coup, meaning the brain ricochets from one side to the other as as the brain moves inside the skull. Skull fractures, like I said, can be open or closed. You still remember what we discussed yet last week about the Monroe-Kelly doctrine, correct? Wherein the patient will have a primary injury, but then there will be secondary injuries that follow. So same exact thing will happen here. If it's a closed head injury, then we will have the Monroe-Kelly doctrine, the principles of it applying as far as increased ICP goes. Here are your types. You have table 39.11. You can have a skull fracture, penetrating injury such as a knife, or it could be a gunshot wound. Concussion is also another term used for mild brain injury. A contusion is an actual injury to the brain tissue, which includes now superficial bleeding, which is different from when you say hematoma. So contusion is there is mild bleeding, however, there will still be some brain swelling, and therefore there will be edema, cerebral edema, because there is actual injury to the brain tissue, however superficial it is. Epidural hematoma, this will definitely increase your ICP because the blood here, the hematoma, depending on the size of the hematoma, does occupy space and therefore will increase ICP. Same thing with the subdural. Doesn't really make a big difference which layer of the meninges your hematoma formation is. They will both occupy space and therefore will increase ICP. Diffuse is so much more serious compared to focal, whereas focal means it's only one area of the brain that is injured, whereas diffuse injuries tend to scatter all over the brain surface, which will increase your ICP faster, and it may also have pose a difficulty with visual examination. As stated here, diffuse axonal injuries can be visualized on MRI but will not be visible before 24 hours after the injury, meaning unlike a focal injury wherein you can see it because it's in one spot, diffuse injuries, because it's involving the entire brain tissue, it is much more harder to detect, especially before 24 hours after the injury, meaning you only see the primary injury, but the secondary injuries of swelling and increased ICP occurs later. Here are some signs of skull fractures. They can be called a battle sign, so you'll see bruising behind the ear, or you can also have bruising around the eyes, which is a raccoon. No, the patient looks like they were punched in the eye, but that is a basilar fracture. And then basal skull fracture, meaning at the base of the skull, will present as a battle sign. Here are, we have pictures earlier. Not here. Right here. So these are raccoon's eyes, and here's your battle sign. So this is basilar, and this is basal skull fracture. Here are examples or illustrations of epidural, and this is a subdural hematoma. As you can see, either one will increase ICP because they are occupying space inside the cranium. Both occur underneath the skull, so therefore, unlike just a bump wherein only the scalp is injured, that's why you'll see a bump. Literally, you'll feel a bump on the head. So that is not necessarily serious. However, you also are not aware that there could be a subdural or a epidural hematoma along with that scalp bleeding. Please read the descriptions on your own. I won't read them for you. Let's go now to diagnosis. Similar to increased ICP and stroke, our diagnostic test is a CAT scan. We need to visualize whether or not the injury is serious, and also to make a diagnosis of mild, moderate, or severe TBI. Management, we already discussed full management of increased intracranial pressure last week. As far as surgery is concerned, the only surgical management is, of course, a craniotomy, the purpose of which is either to stop the bleeding and or evacuation of the hematoma. In order to restore or decrease the intracranial pressure, that hematoma must be removed and the bleeding must be stopped. So here are, that's your surgical management. We'll discuss nursing care, especially post-op, shortly. Here is a summary of your assessment. The main tool again is your Glasgow Coma Scale, in order for you to help determine the severity of the injury, whether it's mild, moderate, or severe. It's important to know this because if the patient has mild injury, they are typically only held for several hours in the ER. They're not necessarily admitted because they do not meet inpatient criteria. Therefore, the doctor cannot justify admitting them because their symptoms are not that serious. However, they will be given instructions specifically when to bring the patient back to the hospital. Because again, bear in mind that even if it's mild traumatic brain injury, there will still be primary and secondary injuries that will follow. And as you already learned last week, secondary injuries do not present at the time of the injury. Similar to what was described earlier, that the under diffuse axonal injury, for instance, that the when do the symptoms present? After 24 hours, correct? In DAI. So similar to mild traumatic brain injury, we may not see the extent of the injury until after 24 hours. All right, so here are your, just like last week, this is not really any different. So monitor your neuro checks every 1 to 2 hours. Vital sign should also be included in that. ECG, why is ECG included here? This is your rationale. Patients with severe, especially severe TBI may demonstrate ECG findings suspicious for myocardial ischemia because of the surge of your fight or flight hormones after the injury. And vital signs, again, that should be done every 1 to 2 hours, along with your Glasgow Coma Scale scoring. And now, if the patient does have a ICP monitoring device, such as the intraventricular catheter we discussed last week, then you have now the ability to calculate your patient's cerebral perfusion pressure. Just like increased ICP, monitor the patient and institute seizure precautions. As far as positioning, is this exactly the same as last week when we talked about increased ICP management? What's the position again? Okay, no higher than 45 degrees. So 30 to 45 degrees is the only acceptable range. Your author only mentions 30, but other authors do allow up to 45, but that would be your highest limit. Anything higher than 45 degrees will cause a sharp hip flexion now. Therefore, it will increase intrathoracic pressure, thereby decreasing venous return from the head, causing distended neck veins, and therefore will increase ICP. If any CSF leak happens, how do we identify it again? What method do we use? Because most of the time,
ICD?
no, for cerebrospinal fluid leaking, no. I mean, all right, I'll specify the question. How do we identify that the patient has a CSF leak? Because the fluid comes out of the nose. So how can you differentiate it from snot? Maybe this patient just having snot. Most
You
of the
see a
time,
halo.
it will be mixed with blood though, because remember, this is head injury. So the drainage may not be clear all the time.
You would
Somebody
see a
said something about, yes, go
halo.
ahead. All right, so that would be the halo sign. So since most of these drainage will have blood along with it, it is not practical to use a dextrose strip in order to test it for glucose, because of course CSF contains glucose. However, since the drainage most likely is mixed with blood, blood has glucose in it too. So that will render your dextrose testing useless, because it cannot distinguish between blood and CSF. So therefore, we're left with the halo sign, which is we will use a dry piece of gauze to dab the drainage, and then if we see a yellow halo ring around the bloody drainage, then that will be a positive sign for CSF. We call that the halo sign. Although we avoid NG tubes or any other invasive tubes in the patient, however, we will have to insert a feeding tube at some point during the admission. This only says avoid. It's, if possible, avoid using it, but on test questions, try to stay away from absolute terms. Let's say when it says never is never the same as avoid. No, it's always a applicable all the time. No, so avoid absolute terms like that.
I have a question.
Yes,
So
boss.
like if you don't have blood, I don't know if you'd mentioned this, like, and how would you use the halo? You would just send the CSF to the lab and like see if it has glucose?
It's hardly ever clear, but if it is clear, no, not a drop of blood in it. I mean, you can see there's nothing red in it. Yes, you can just test it for glucose. Here's your enteral nutrition. Oftentimes with critical patients like these, we are so busy saving their lives, monitoring their vital signs, neurochecks, hemodynamic parameters that we forget that the patient needs to eat. Of course, the patient is unconscious, so that means our feeding here will either be via NG tube or via PEG tube. Regardless, the patient will require a high calorie feeding because they are in a hypermetabolic state brought about by the severe injury. And remember, the brain consumes 25% of the body's glucose. So the more calories these patients will require because the brain's metabolic activity here is of course increased. We already learned this last week that we need to achieve normal or even a little bit low temperature is desired in all increased ICP patients. And here's the seizure precautions. And here are your interventions for that. We can initiate prophylactic anti-seizure medications. Usually they use levetiracetam as a prophylactic choice. And because these patients are bedbound, if not unconscious, then institute DVT prevention. Here are your teachings. Any question on traumatic brain injury? So as you can see, TBI was simply an example to illustrate how increased ICP occurs in a patient, and you saw exactly the management were the same. It did not change. You had a question, Israel?
Oh no.
Oh. All right, let's proceed to chronic conditions now. So we finished the acute conditions now. You did stroke in MedSearch 1, and now we have finished um, increased ICP as well as um, TBI. We have already discussed neurogenic shock under the first module. I hope you still remember this. This is a complication of spinal cord injury. This is the first chronic condition we will be covering. You still remember myasthenia gravis correctly, right?
Yeah.
What was the problem in myasthenia gravis again?
Well, worst case scenario, they could stop breathing because they muscles, basically like their muscles stop working. It gets weak and then they pause, like with the breathing, their breathing muscles, like the sun muscles and stuff, they just stop working. They can't breathe
Okay,
in
so
effect.
all right, they get weak with any repetitive activity, correct?
Yeah.
What were you saying, Miss
I
Cheston?
said they lack acetylcholine because of the destruction of the binder or something.
Okay, kinda, sorta.
Yes.
The acetylcholine levels here, acetylcholine again is a neurotransmitter we need in order for muscles to work. A little review of our physiology is how our muscles work and contract is because of the acetylcholine, which is again a neurotransmitter, which will stimulate muscle contraction. So it constantly runs across neurons from one axon to the next. Anticholinesterase is a naturally occurring substance along the neuron. This is necessary in order to destroy acetylcholine, because otherwise, how can a muscle contraction ever stop? So we have acetylcholine as well as anticholinesterase, both present in the neurons. So again, for the purpose of acetylcholine is needed for muscle contraction, and anticholinesterase is needed in order to stop the muscle contraction. Otherwise, it will never stop. In myasthenia gravis, we had it was an autoimmune disorder which destroyed the acetylcholine receptors from one neuron to the next. Since we did not have enough receptors for the acetylcholine in order for it to travel from one muscle to the next, that's why we gave anticholinesterase inhibitors, so that even though we don't have enough receptors, if we allow acetylcholine to hang around longer, then we can sustain a muscle contraction, meaning we will just inhibit the anticholinesterase in order to allow acetylcholine to hang around longer. In Parkinson's, the problem lies not in acetylcholine nor the acetylcholine receptors, but rather on dopamine. Dopamine is produced in the substantia nigra portion of the brain. We don't know really what the primary cause is leading to the decreased levels of dopamine. What is dopamine? It is also a neurotransmitter. It's responsible for maintaining blood pressure as well as for controlling movement. So in the case of Parkinson's disease, we need dopamine in order for us to control muscle contraction, meaning muscles are not just moving on their own, but with purpose, meaning in order for you to grab an object, for instance, there has to be enough levels of dopamine in order for you to control any muscle movement. So let's say you intend to grab the remote control from the TV. You can do that because you have dopamine. When you have low levels of dopamine, though, what will happen to purposeful muscle movement? Is it going to be smooth and purposeful? No. The patient, therefore, will have tremors. They will have difficulty with intentional movements because they have less of the dopamine. As you can see here, it's primarily idiopathic, meaning we don't know the cause. We do have some suspicion that it could be caused by environmental toxins, or it could come from brain injury, brain tumors, but basically nobody knows for sure what causes Parkinson's disease. That's why we currently have no cure for it. These are the incidents of its occurrence. More males than females. Right here, more males than females. here is your problem again. So you have a decreased amount of dopamine. Because of this pathophysiology, therefore, what do you think will be our treatment without looking at medical management? What's the problem again in Parkinson's disease? They don't have enough dopamine. So, again, what do you think will be the treatment?
Dopamine.
All
Like
right, so
Levodopa.
therefore, all right, so we will therefore give the patient some dopamine or allow dopamine to hang around longer as well, just like acetylcholine. Okay, so that is our goal. Let's go with manifestations first. So imagine someone who doesn't have enough dopamine to control muscle movement. The acronym is called TRAP, T-R-A-P. So that stands for tremors, rigidity, akinesia or bradykinesia, and then the P stands for postural instability. So here is a typical picture. They all look alike. Famous figures we've seen are Muhammad Ali as well as Michael J. Fox. You've seen them on TV. What happened to their facial expression? None, right? They have a mask-like appearance, meaning it's extremely hard to make facial expressions. Smiling or any other facial gesture is close to impossible. They have constant tremors, although if given medications and a good combination of medications, they can control these tremors. The tremors here are different from multiple sclerosis in the sense that these are tremors, meaning the moment the tremors appear. So that's why you've probably seen Michael J. Fox when he appears on the few times that he goes on TV nowadays for interviews. He keeps moving from side to side. He keeps shifting his weight left to right because he has learned, I'm sure, that when he stops moving, the tremors are hard to control. So in order to avoid that, he just keeps moving so that the tremors will not be so evident. So they'll have these postures like this. They have a shuffling gait, meaning they will appear as if when they walk, two things. They will have a magnetic gait as well, meaning let's say the patient wants to move this left foot, right? So they'll have a hard time moving it because it'll feel like the foot is stuck to the floor. So it's like that's why they call it a magnetic gait. But once they get moving, once this foot gets moving and then the other foot follows, they have a shuffling gait. They will look like they have a hard time stopping when they do get started to walk. So they'll have a forward posture. It will look like they're about to fall smack on their face, but um, not really. That's just how they ambulate. So that's what we call a shuffling gait. They will have muscle rigidity because again, the problem here is you have no control over your muscle movement, or you have very poor control because of the deficiency of your dopamine. As a result, when muscles contract, they become rigid. They typically have this stoop posture. And remember, this is from head to toe, from his head down to his legs and feet. So chewing here will also be a chore. It's it's dangerous. They could choke. while eating because of the tremors. Diagnosis is not that easy. Typically, the doctor will make a diagnosis based on the clinical symptoms, the patient's complaints, and of course, the low levels of dopamine will help with the diagnosis. A CT or MRI of the head will help rule out other causes such as tumors, for instance, or it could also be used to rule out Alzheimer's disease. Because in Alzheimer's disease, the brain shrinks. There is no shrinkage here in Parkinson's.
Oh,
The sad thing about the disorder is they have these features, but then they are cognitively intact, meaning they are fully aware. There's no deterioration of intelligence here. They are the same person in their mind, meaning mental function wise, they are completely normal. Is that their body is failing them, and of course that will lead to depression because now social activities will be very um, stressful for them because they know how they look and they have no control over these. So they're not the same as they used to be, and they might find that embarrassing. So that will snowball into depression, social isolation, anxiety, etc.
Professor,
Yes.
in the case of like Muhammad Ali, did he get Parkinson really because of like boxing, like all of the hits that he took to the head, like shaking his brain?
Michael J. Fox didn't have them though.
No, no, no. I
So
said
that's
Muhammad
the
Ali.
yeah. So like I said, the cause really is idiopathic because I mean we've seen a lot of boxers also. Like look at Mike Tyson. How many hits these people have had. George Foreman, for instance. So we can't really say that repeated head trauma leads to Parkinson's because otherwise all boxers would have it. So the I would still stick with the idiopathic origin, meaning we really don't know. Because if
Okay.
we did, like I said, we would have a cure for this already. We really don't know what causes it. We know some risk factors which were identified earlier, like toxins, such as insecticides, for instance, or other chemicals. But there's really no one cause that we can really pinpoint toward as a cause of Parkinson's disease.
Okay.
Uh, the only treatment is medications. Like I said earlier, most of these drugs will either be dopamine to increase your levels of dopamine, or this could be drugs that will allow dopamine to hang around longer and not deteriorate. Because just like acetylcholine, we have anticholinesterase, which will also destroy dopamine. So therefore, if we give them drugs to either increase their dopamine level or by decreasing the destruction of decreasing the rate of destruction of dopamine, or giving them anticholinergics, for instance, to reduce the tremors, in which case this is now not really directed toward the movement, but rather the uh, more of a supportive or symptomatic treatment of Parkinson's, because again, they have little control over these muscle movements, especially with tremors and the drooling, which can cause aspiration or just embarrassment in society. Because imagine drooling during a party, for instance, that you're just sitting there because you cannot have a very good movement on your mouth. So anticholinergics will help in these instances. So that's one group. We use anticholinergics. The specific drugs we're using are trihexyphenidyl or benztropine. Benztropine has been around for a long time since I've known Parkinson's as a new nurse. This has already been used and it's still very useful today. The only warning here is, as you can read here, use with caution in older adults. And for these reasons, for these side effects. Besides the dry mouth and constipation, this actually causes exacerbation of heart failure. So definitely, if a patient has heart failure, do not use anticholinergics. Next group of drugs are dopamine receptor agonists. So this will help um, promote the enhance the activity of dopamine by enhancing its movement across receptors. You probably heard of ropinirole also, which is used in restless leg syndrome. So it has similar symptoms with Parkinson's, but at least with restless legs, literally it's just your legs that is the problem. Patients still need help with that because, of course, imagine your legs keep twitching at night. Can you sleep? No. So this is
No.
also, yeah, so this for those people with restless legs, they have to be treated with Requip or ropinirole. But for Parkinson's, this is the dopamine receptor we use. Although we still use ropinirole, but this one is more common. These are your side effects. So you already know what the questions on the test will be. Now, I'd like to emphasize that Parkinson's disease is a chronic disorder. Look at Michael J. Fox, for instance. How old was he when he was diagnosed? He was only in his early 40s when he got it. Muhammad Ali, about the same, but I think Ali was already in his 50s when he got it.
Yeah.
And so therefore, how long will they be on these medications?
Forever. For the rest of
Forever.
Forever.
Yeah. So imagine taking the same drug forever. Is that drug still gonna work after several years?
Wouldn't they build up tolerance?
No.
Exactly right. So these patients tend to develop tolerance to these drugs over time. So that's why of all the neuro disorders we'll talk about, these guys will have the most number of medications because what will happen is over time these drugs no longer work, so we will have to switch them from one drug to another. So after several years, when this patient now complains that the symptoms are getting worse, the drugs no longer work, the doctor will switch them from one drug to another or add another group of drugs to the existing therapy and all other combinations. Are we clear with this?
Yeah.
Yes,
All
Professor.
right. Okay. So as you can see here, this is the initiation of treatment. They'll be started on these drugs first, and then next will be these drugs, and then another with when they progress, when the Parkinson's disease gets worse over time, then they'll be started on levodopa. Yes, this is Cinemet. Levodopa is actually I've never seen it given on its own. The form usually given is carbidopa and levodopa. This is Cinemet. It's the cheapest of all the drugs. This is literally um, dopamine. So the dopamine here is levodopa. It's a precursor of dopamine, meaning when it. Another problem here with the treatment is how many drugs do you know that can cross the blood-brain barrier? Not many. So that also limits our choice and also makes these drugs even harder to work. So that's why for Levodopa, it's better given if it's in the form of carbidopa and levodopa. Because when levodopa crosses, because this one can cross the blood-brain barrier, but as it crosses though, it is destroyed on the other side once it enters the cerebral circulation. So to keep it from being destroyed, that's why they add the carbidopa so that it is still viable as it crosses the blood-brain barrier, which makes Cinemet more effective compared to just levodopa. So there are different reasons here that these drugs will be used. For instance, look at this paragraph here. Levodopa seems to become less effective in the elimination of motor symptoms. These patients will have on and off episodes. On meaning they're doing good, meaning the drugs are working, but then they will have off or wearing off episodes, meaning they will have more tremors, more ambulation problems, more eating problems over time. So they know already that they'll have on episodes and off episodes. So these are the times that they call their doctor, hey doctor, I'm having off episodes now. And the doctor will start switching their medications. Over the years, these patients will become experts with these, and they kind of anticipate already what their doctor will do. However, they will still have to be supervised when they are changing medications. So here for Cinemet, these are most effective in the treatment of bradykinesia. Bradykinesia is slow movement, then tremors and rigidity. These are your side effects. Remember that dopamine helps you maintain blood pressure, correct? Because they have less dopamine, so therefore what will be their blood pressure most of the time? It'll be low.
If you give them too much of this, they can have
Yeah, because now both the condition and the drug causes hypotension. So be careful when patients are on Cinemet. Monitor their blood pressure. There are surgical managements, but I mean, look at the rich celebrities that do have Parkinson's disease. Were they ever cured? I'm sure they had the capacity, financial ability to undergo these surgeries, but yet I'm sure some of them have, but are they really effective?
No.
No. So let's forget about the surgical management. So we'll skip that because all of your patients will be on drug therapy anyway. And again, our concern here are the management of your signs and symptoms, making sure they stay safe. So let's stick with the drug therapy listed here, from anticholinergics to dopamine receptor agonists to levodopa and carbidopa levodopa. There are many more, but since these are the only ones mentioned in your textbook, then these are the only ones I can test. Other medications not listed here include amitriptyline, for instance, which is an antiviral medication. It also helps with the dyskinesias. We also have um, the others are more for the symptoms. Let's say these patients will have some muscle spasms, so they'll be given baclofen. And like I said earlier, they may develop depression, so they'll be put on antidepressants. Very seldom, though, there are cases wherein these patients develop hallucinations. They're not really sure if it's caused by drugs, but the drug therapy, as you can see, don't really have hallucinations as a side effect. I mean, I don't remember reading any of them, but um, Parkinson's patients have been known to have hallucinations over time as the disease progresses. Some of them eventually have Alzheimer's disease. If Alzheimer's again is another condition wherein we don't know the cause, but of course, if they develop Alzheimer's, then of course the cognitive ability is now affected. So here's your summary for your signs and symptoms, and then here are your interventions. I already mentioned the aspiration danger. Here is your acronym. So just add the postural instability there. So most of our interventions again are geared toward medication management. These patients continue to live independently. Not all of them are placed in an institution. They continue to live at home, some independently. By independently, I mean they live by themselves with no caregiver. In those instances, they are monitored though by telehealth. So that's an opportunity for you guys if that's what you want, work from home. You monitor these patients from all over the country. So you could be based in New York and your Parkinson's patients are in California or in Washington State, for instance. So we have services for these. Like I said, they like, we all like our independence, right? I mean, who wants to be in a nursing home? So they stay at home, but they are monitored regularly via telehealth, and that's where nurses come in. So these are your interventions when they are institutionalized or hospitalized. Nutrition, ear aspiration precaution, suction equipment just in case they do aspirate. Stool softeners, we had the constipation earlier, especially when taking anticholinergics. And this will help. That way they don't feel so isolated, and also to keep them active. And this will not, not this is not bad if they also continue with physical therapy, speech therapy, occupational therapy, just to maintain independence. With communication, you've probably seen Muhammad Ali speak in public. It's hard, right? It's hard to see when they talk. They have a difficulty with speaking. But again, there's no problem with cognition here. They are as smart as they were. It's just that speech will be quite difficult. So it'll be they may have some slurring of words sometimes, or just difficult to get the words out or to speak in straight sentences. And these are self-explanatory. Any question on Parkinson's? Okay, let's take a short break. Come back at 2:05.